Welcome back guys. Now in this video let's discuss about the topic of infertility. Now in the beginning let's discuss about the male factors of infertility, later discuss about the female factors of infertility. So now to begin infertility, first of all let's discuss a few important basic points. Now please see guys here, in a male during puberty the arcuate nucleus in the hypothalamus is going to be activated and it is going to produce gonadotropin releasing hormone. This gonadotropin releasing hormone, it reaches the anterior pituitary, and from the anterior pituitary the gonadotropes are going to release the gonadotropins, which includes follicle stimulating hormone and luteinizing hormone. So what is the function of this follicle stimulating hormone and luteinizing hormone? Their main function is that to produce testosterone, and they also help in spermatogenesis. Now please concentrate, follicle stimulating hormone is going to act on which cells? It is going to act on Sertoli cells in the testis, and now whenever the FSH is going to act on the Sertoli cells are going to make inhibin. Guys please concentrate, wherever you see inhibin all the time gives negative feedback to the follicle stimulating hormone. Okay, that's a very important point. Even when we are discussing about a menstrual cycle, there we have discussed inhibin B released from the granulosa cells, inhibin A released from the corpus luteum. What is the function of inhibin A and inhibin B in the female guys? It is the negative feedback, it gives negative feedback to the FSH. Even in the male, the FSH is negatively down regulated by inhibin produced from Sertoli cells. Now the luteinizing hormone is going to act on the Leydig cells, and now Leydig cells under the action of LH is going to produce testosterone. So how to remember this? LH, L word, okay, letter L is going to act on Leydig cells, L for L, okay, try to remember it, something like that. Now the testosterone, it is going to help in the process of spermatogenesis, okay, very important MCQ. Now after saying this, let's discuss a few important our physiology related points. Now we all know that spermatogenesis is happening in the testis, but these sperms, they should be stored in one place. So where exactly sperms are getting stored, and where these sperms are getting matured, and what is the exact place where attain the motility? So these are the MCQs. So the storage of the sperms and even motility as well as the maturity, they are attained in caudal epididymis. Okay, now let's talk about the seminal vesicle for a minute. Guys, the seminal vesicles which are present in a male. So what is the function of this seminal vesicle guys? So these seminal vesicles are going to release the secretions which almost makes 50 to 60% or somewhere around 50% of the semen. See, semen and sperms, they are not one and the same. Now important point is that these seminal vesicles, they are going to make the secretions which makes the bulk of the semen. So that's the important point, and these secretions are alkaline in nature. So alkaline secretions, okay, which makes almost 40 to 50% of the semen. Now what about the prostatic secretions? Guys, the important point about the prostatic secretions is such, it's going to be acidic in nature, and these prostatic secretions are going to help in the process of liquefaction. So now you can ask me, what exactly is liquefaction? The moment the semen is going to be ejaculated from the penis, the semen is going to be of a thick consistency, but as time passes by, with the time the semen will become more liquefied. So that is known as liquefaction, and for that process of liquefaction it needs the prostatic secretions. Okay, so what is the time for liquefaction of the sperms? It takes somewhere around 20 minutes for liquefaction. There is one more point I just missed here. See, seminal vesicles, they are making the alkaline secretions and they are making the bulk of the semen, okay. But these alkaline secretions, they also have fructose in them. Okay, so the MCQ is fructose is added to the semen by which glands? Seminal vesicles. Now after saying this, let's see the sperm pathway. Okay, what does I mean by sperm pathway? How the sperms are actually being transported from the testis to the penis. So this is the sperm pathway. You can clearly see over here that the sperms, like they are present in the epididymis. From there they are reaching the vas deferens, and these vas deferens, it is going to the seminal vesicles. See, you can see clearly here that seminal vesicles, they are going to add their contents into the vas deferens. Now this vas deferens is going to enter into the prostatic gland. Now these prostatic secretions are also going to be entered into this duct. So now here this duct is known as ejaculatory duct. Now after this ejaculatory duct comes out of the prostate, now it is the urethra, and this urethra is going to enter into the penis, and from there the sperms are going to be ejaculated. So this is the basic sperm pathway. Now after this, please concentrate the exact definition of infertility. Now we are starting the real topic of infertility. So what is the definition of infertility? The definition is that there are these couple who are having intercourse without any protection or without any contraceptives. Okay, there is this couple, they are having unprotected intercourse or unprotected sex. They have tried to have the pregnancy for 1 year. They are having the intercourse for 1 year without any contraceptives, but still they fail to achieve the pregnancy. So the definition is that 1 year of unprotected coitus without conception, okay, in a female younger than 35 years. So I am talking about a female younger than 35 years. That this couple, they are trying to make the pregnancy, but they are failed to achieve the pregnancy even without any contraceptives. So that's what the important point. But the definition slightly changes if the female age is more than 35 years. Now if the female age is more than 35 years, we are not going to wait till 12 years. We are going to reduce the time by 6 months. So 6 months of unprotected coitus, still there is no pregnancy. Now they should be considered as infertile couple. But usually, infertility is a synonymous term to subfertility. Why? Because if you give enough amount of time, if they try, there are chances that most of these couple who are thought as infertile, they will become parents, which means it's just the time, okay, which determines the fertility. If you just give some extra time, if they are more indulging themselves in sexual activity, now there is possibility that they will again become pregnant, okay, she will again become pregnant. That's what I am trying to put into your mind. Now let's see the causes of the infertility. Guys, actually the male is responsible for almost 20 to 30% of the cases of infertility, which means the male alone is responsible for 20 to 30% cases of infertility, and female is responsible for 30 to 40% cases of infertility. But male and female factors combined, it comes somewhere around 10 to 40% of the cases. In 10 to 40% of the cases, both the male factors and female factors are leading to the infertility, and unexplained causes of infertility, it will be somewhere around 10 to 20%. Okay, so 10 to 20% of the cases we don't know what exactly causing the infertility. Now, okay, there is this couple came to you and they are saying, sir, we are having we are trying the unprotected sex for the last 1 year, but still we are not conceiving. Now what is the first investigation you will be doing? See, there might be problem with the male partner or there might be problem with the female partner, but what is the first investigation to be done in a couple of infertility? The answer always is semen analysis. You have to start your investigations with the semen analysis. Why? Because semen analysis is very easy. If you are going to female, there are many causes of female infertility, something like ovarian causes, tubal causes, uterine causes, cervical causes. So female reproductive system is more complicated when compared to male reproductive system. So investigations in male are very simple. So always start the investigations with the male, that is the semen analysis. Okay, well and good. Now please concentrate WHO 2010 gave certain parameters how exactly the semen should be. What are the normal minimal values a semen should have? Now see, the volume of sperms are like the volume of semen is important, pH is important, sperm concentration, sperm count, sperm morphology, sperm movement, lot of things are important. But out of all the parameters, what is that one parameter which is of utmost importance? So this is a very important MCQ. Out of all the parameters, is it sperm concentration which is important? Is it sperm motility? Is it sperm morphology? Guys, please concentrate. It is the sperm morphology which is a very important parameter. It's the most important parameter. Now after saying this, how much amount of semen should be released by a male? It's a minimum value. It should be more than 1.5 ml. Okay, so more than 1.5 ml should be released during the sexual activity. Now what should be the pH of sperm? It should be acidic or basic. It should be mostly towards the basic side. The ideal pH should be 7.2. Okay, more than 7.2 is considered as ideal pH. Now what should be the sperm concentration? In 1 ml of the semen, how many number of sperm should be there? More than 15 million sperm should be there per ml of the semen. So important MCQ, more than 15 million per ml. Now the question is, what if in 1 ml the sperm concentration is less than 15 million? So that should be considered as less number of sperms. So that is termed as oligospermia. So what is the ideal count of sperm, guys? More than 15 million per ml should be there. Now what about the sperm count? Now sperm count, what does I mean by, in the entire ejaculate there should be at least 39 million per ejaculate should be there. 39 million sperms per ejaculate. Okay, so well and good. Now sperm morphology, the very important criteria, the very important parameter, how many number of sperms or how much percent of sperms should have their normal morphology? At least 4% of the sperms. Okay, so 4% or more than 4% of the sperms should be having normal morphology. Okay, now what about the total motility? The total motility should be more than 40%. Out of this, out of total number of sperms, at least 32% should be actively motile. Okay, active motility. So active tail beating should be there, and like they should be progressively motile. So 32% should be actively motile, and out of all the sperms, do you think all sperms will be alive? No. So how many number of sperms or how much percent of sperms should be viable? 58% of sperm should be viable in the semen. Now what about the WBC count? Guys, if there is any infection which is happening in the pelvic region, which is happening in the testis, for example, there is this infection in the testis. Now definitely the WBC are also going to enter into the semen. Now having more number of WBC can cause infertility. Why? Because these leukocytes are going to create inflammation. These leukocytes will produce a lot of cytokines which will hamper the spermatogenesis and which will hamper the movement of sperms also. So WBC count should be less in the semen. That too, they shouldn't be more than 1 million per ml. So less than 1 million per ml is desired. Okay, so well and good. Now total number of round cells. What does I mean by round cells? Guys, sometimes the sperms will be more globular in shape. They are known as the globular cells, and even WBC are also globular. So round cells is nothing but globular sperms and WBC. Their count, their count together should not be more than 5 million. So it will be less than 5 million. It should be less than 5 million. So these are some important WHO 2010 parameters for normal semen. Okay. Now after this, see, let's talk about certain important conditions and their terminology. For example, you have done the semen analysis. Okay, you just ask the male partner to go and bring the semen. Now this male partner is not bringing any semen, which means, like, he is not getting any semen. So this should be termed as no semen is coming. This should be termed as aspermia. So what exactly is aspermia, guys? Aspermia means no semen is coming. It's not just sperms, no semen at all. Now, if there are no sperms, what does I mean by, see, there is this semen, but sperms are not there. So this should be called as 𝐒𝐮𝐬𝐫𝐞. Okay, well and good. Okay, sir. Now he just bought the semen in the container, and now in this semen there are sperms but less number of sperms. Now if it is less than 15 million per ml, it should be called as oligospermia. Now if the sperm count is less than 5 million, which means very less number of sperms are there, now this should be considered as severe oligospermia. Okay, well and good. Now there are sperms but they are not actively motile. There are sperms which are even non-motile, absolutely non-motile. So they are weak sperms, they are unable to move. So that should be termed as asthenozoospermia. Okay. Now what about the dead sperms? There are sperms but all of them are dead. So they should be considered as necrozoospermia. Okay. Now abnormal morphology, there are sperms that are moving but their head, their neck or the body piece or the tail, they are abnormal. So that should be considered as teratozoospermia. Okay. Now increased WBC in the sperms, there are more number of leukocytes. So leukocytes, it is leukocytospermia. Okay, leukocytospermia. Okay, so these are certain important terminology which need to be kept in mind. Why? Because they will ask you. Especially the important thing is oligospermia, less than 15 million per ml should be considered as oligospermia, and less than 5 million is severe oligospermia. Okay, now after this, please concentrate, guys. Okay, all this is completed. Now guys, in these slides it's very clear that on one side you can clearly see there are more number of sperms. Okay, normal seminal sample you can see more number of sperms, but on the other side there are no sperms at all. Okay, now here in this slide you can see on both the sides sperms are there, but on one side the sperm count is very good, but on the other side there are only very few number of sperms. Okay, now after this, here please concentrate. On one side the sperms are there, both the sides sperms are there, but on one side the sperm motility is very good, but on the other side the sperms are not motile, which means asthenospermia is there on one side, on the other side the sperms are actively motile. Now after this, guys, here in this slide you can see, for example, here the sperm is having two heads, or you can see there is this globular sperm. So abnormal morphology means teratozoospermia. Okay, so these are some important points need to be kept in mind. Now let's see a few important points about azoospermia. What actually I mean by azoospermia? Azoospermia means semen is there, but in that semen sperms are not there. Now what are the reasons why a male is not making the sperms? Why spermatogenesis is not happening, or the reason why there are no sperms in the semen? Why sperms are absent in the semen? Now the causes might be at 3 levels. So which includes pre-testicular causes, testicular causes and post-testicular causes. Now if I am talking about pre-testicular causes, the problem lies at the level of central nervous system. The hypothalamus and pituitary gland, they are failed to produce GnRH, FSH or LH. So if there are no gonadotropins, how come the testis is going to make the sperms? So the important point is that in pre-testicular causes, central nervous system is having a defect. Now in testicular causes, the cause lies at the level of testis. For example, there is this testicular tumor, or there is some injury to the testis, trauma to the testis. So that's why spermatogenesis is not happening, and at the end in the semen no sperms are present. Now, if I am talking about the post-testicular causes, central nervous system is absolutely alright, testis is absolutely alright, but the outflow tract, the outflow pathway, vas deferens, ejaculatory duct, prostatic urethra, penile urethra, there might be some blockage in the sperm pathway, so that sperms are not entering into the semen. So these are the main important causes. So pre-testicular cause, the cause lies at, the problem lies at hypothalamus or pituitary. In testicular causes, the cause lies at testis, and in post-testicular causes, the problem lies at the level of sperm pathway. Now, let's see how to differentiate whether the patient is having, whether this male patient is having a pre-testicular cause of azoospermia or testicular cause of azoospermia or post-testicular cause of azoospermia. Now, with hormonal studies, we can put the diagnosis. Guys, please concentrate. If there is problem lies at the level of central nervous system, LH will be less, FSH will be less, and testosterone levels will be less. Okay, why? Because there is less amount of LH, less amount of FSH. So, ultimately, the testosterone levels will also be low. Now, if there is a problem lies at the level of testis, there is no problem with the central nervous system. But testis is not making the sperms. So, what central nervous system will try to do? It will try to produce as much amount of LH and FSH. But there is problem in the testis. So, testosterone level will be less. So, LH will be more, FSH will be more. Why? Because central nervous system is trying to produce sperms. But as the problem lies in the testis, testosterone levels will be low. But in a post-testicular cause of azoospermia, the problem is at the outflow tract. Central nervous system is absolutely normal and testis is absolutely normal. So, LH levels will be normal, FSH levels will be normal, but testosterone levels are also normal. All of them are normal. Okay, that's the one important point you need to keep in mind. Now, after this, let's see what are the reasons why there is this pre-testicular cause, testicular cause and post-testicular cause. We have already discussed, but let's have a recap. Now, pre-testicular causes might be because of pituitary tumors, or because of hyperprolactinemia, or because of the 𝐒𝐫𝐢𝐻 syndrome. Okay, we are going to discuss 𝐒𝐿-Mann syndrome in detail in the topic of amenorrhea. Okay, but for now, please concentrate. The pre-testicular causes includes pituitary tumors, hyperprolactinemia, 𝐒𝐿-Mann syndrome, etc. But please concentrate the testicular causes of azoospermia, which means the problem lies at the level of testis. See, the causes include Klinefelter syndrome. Yes, in Klinefelter syndrome, what happens? There is azoospermia. The testes are not making the sperms. Klinefelter syndrome, it is 47XXY. Because of the presence of some extra X chromosome, the spermatogenesis is hampered. Okay, now the Y chromosome microdeletion, injury to the testis, tumors, varicocele, all of them are the testicular causes of azoospermia. Now you can ask me how varicocele is going to cause the azoospermia. See, in varicocele, what exactly is happening? It is the dilation of the veins in the testis. If there is dilation of veins in the testis, there is more blood congestion inside the testis. Whenever there is more amount of this warm blood present inside the testis, because of this warm temperature, spermatogenesis can be hampered. To have a normal spermatogenesis, the temperature should be less than 2 degrees when compared to the body temperature. So that is the reason why testes are present outside the body. But in the condition of varicocele, because of the high temperatures due to the congested blood, spermatogenesis can be hampered. If I am talking about the post-testicular causes, guys, please concentrate here. I hope you can see this. Cystic fibrosis. Okay, cystic fibrosis, we have already studied. It's because of the CFTR gene mutation. Salty babies will be there. Okay, there will be thick secretions. So even sperms are nothing but the secretion. Semen is a secretion. So here the secretions will be very much thick and they will block the sperm pathway. So cystic fibrosis, or if there is the syndrome known as immotile cilia syndrome, the cilia are not properly beating, so that the secretions are going to be getting stagnated in the sperm pathway and they are blocking the pathway. or because of some infection or congenital bilateral vas difference absence, or like because of the erectile dysfunction, all of them may be a post-testicular cause for azoospermia. So azoospermia can be because of a pre-testicular cause, testicular cause, or post-testicular cause. Okay, after seeing the causes, now let's discuss about obstructive azoospermia, which means the third category. There is this obstruction, because of that there is azoospermia, sperms are not present in the semen. Now guys, a very important point is that if there is a block at the level A, what does I mean by block at level A? The block is present above the seminal vesicle. If there is a block in this region, how we will know? Or if there is a block in this region at point B, how we will know that whether the block is present over the seminal vesicle or below the seminal vesicle? How means, please concentrate. If there is a block at level A, now the seminal vesicle contents, are they going to enter into the ejaculatory duct and they are going to enter into the prostatic urethra, penile urethra, and at the end the seminal vesicle contents, they are going to be coming out. So whatever the semen came out, does it have fructose or not? Yes, it have fructose. Why? Because the block is present over the seminal vesicle. Okay. Now if there is a block at level B, now the seminal vesicle contents, they are not able to enter into the semen. So what happens? Whatever the little bit amount of semen coming out, that semen is fructose negative. So very important point, how to know where the block is present, above the seminal vesicle or below the seminal vesicle. See, if the semen is showing fructose positivity, which means the obstructive azoospermia, the obstruction lies over the seminal vesicle. But if the semen is showing fructose negativity, which means the block is present down to the seminal vesicle, so that the seminal vesicle contents are not entering into the semen. So the semen will be fructose negative. Okay. Now after this, you can, in this video, you can clearly see that on one side, like you have taken the semen and you have added the reagents. On one side it is coming fructose negative, and on the other side it is coming fructose positive. Okay. Now let's talk a few important points how to retrieve the sperms. What actually I am talking about, guys? See, there is this obstructive azoospermia, which means sperms are there, sperms are getting produced, but they are unable to come out. So what I have to do? I have to retrieve the sperms, and now with this sperm retrieval, I have to get the sperm and I have to fertilize the ovum. So these are certain sperm retrieval techniques which are used in obstructive azoospermia management. They include TISA. What exactly is TISA? It's a testicular sperm aspiration. I am going to grab the testis and I am going to aspirate the sperms. I am going to put a needle and I am going to aspirate the sperms directly from the testis. That is testicular sperm aspiration. Or else I can go with the testicular sperm extraction, which means I am going to take a chunk of testicular tissue, and from this chunk or from this biopsy, I am going to take out the seminiferous tubules, and from the seminiferous tubules, I am going to extract the sperms. That is testicular sperm extraction. Extraction is it's the biopsy. Okay. Now let's talk about the PISA. What exactly is PISA? PISA means percutaneous epididymal sperm aspiration. We all know that sperms are stored in the epididymis. They got maturity and motility in the epididymis. So I can directly put the needle into the epididymis and I can aspirate the sperms. That is a PISA. Now let's talk about the MISA. MISA is very important and it's the best, because what exactly I am doing in the MISA? MISA is a microsurgical epididymal sperm aspiration. So I am going to use a microscopic instrument. I am going to I am going to aspirate the sperms directly by using the microscope. With the help of a microscope, I am going to take out sperms which are healthy looking, which are having good morphology, something like that. So this is something best. So out of all the sperm retrieval techniques, which is best? It is the MESA. Okay, well and good. Now let's see the overall management of male infertility. Guys, male infertility is most of the time because of the oligospermia. Now there is this male who is having less number of sperms. Now how to manage? Guys, please concentrate. We can do a medical management. If there is oligospermia, we can do medical management by giving clomiphene citrate. But apart from clomiphene citrate, we can try certain methods like intrauterine insemination, in vitro fertilization, intracytoplasmic sperm injection, when they should need to be done. Guys, there is this oligospermia. The count of sperms are somewhere between 10 to 15 million. See, normally more than 15 million sperms are needed. According to WHO, more than 15 million per ml are needed. But there is our person, there is this male who is having 10 to 15 million sperms. Now in this person, we can try intrauterine insemination, which means we are going to take the sperms, we are going to wash his sperms, we are going to concentrate his sperms, and we are going to extract that sperms which are only motile sperms, and we will be taking this sperms and we will be putting it directly into the uterine cavity of the female, which means we are increasing the chances of fertilization. We are simply bypassing the cervix and we are releasing the sperms directly into the uterus near to the fallopian tubes. That is intrauterine insemination. Now the sperm quantity is still low. That is, sperms are somewhere around 5 million. But 5 to 15 million is okay to do in vitro fertilization. To perform in vitro fertilization, he need to have 5 to 15 million sperm count. What I am trying to put into your mind, if the sperm quantity is less, that is 10 to 15 million, you can go with the intrauterine insemination. But still the sperm quantity is less. Severe oligospermia, not exactly severe oligospermia, the sperm count is more than 5 million but less than 15 million. For example, 6 million, 7 million, 8 million. Now in these cases, you can try in vitro fertilization. Okay. Now, if there is severe oligospermia, which means I have already said you less than 5 million. Less than 5 million is a very less count. Now in these cases, we are not going to take any chance. We will be directly getting the sperm. Okay, we are going to get that one sperm which is healthy looking, actively motile. Now this sperm was directly injected into the ovum. Okay, we are doing it with our hand. So that is known as intracytoplasmic sperm injection. So intracytoplasmic sperm injection is indicated if there is a severe oligospermia. Okay. Now if there is obstructive zoospermia, guys, we have already discussed, if there is obstruction, we have to retrieve the sperms either by a TSA, TSA, PISA or MISA. We have to extract. So that is in obstructive azoospermia, what we are doing? We are doing sperm retrieval. After retrieving the sperms, we are going to do intracytoplasmic sperm injection. So these are certain important managements which are done for the patient who is having oligospermia and obstructive zoospermia. Now in this video, you can clearly see the needle was directly placed into the epididymis and sperms are aspirated. This is PISA. Okay. Now after this, let's see, in this video you can directly see that needle was directly placed into the ovum and the sperm was directly released into the ovum. This is intracytoplasmic sperm injection, which is indicated in a male who is having severe oligospermia, or this is indicated if the patient is having obstructive azoospermia. What we are going to do is we are going to do the sperm retrieval and we are going to do the intracytoplasmic sperm injection. Okay. Now after this, in this video you can clearly see intrauterine insemination, directly the sperms are released into the uterine cavity. So intrauterine insemination is indicated in oligospermia with the sperm count present between 10 million to 15 million per ml. So this is all about the male infertility. I hope I have covered all the important topics. Hope the video is helpful. Thank you.